controlled by medication. They're continually having seizures. The problem with
got a
seizures
storage
is
issue. That's the
it
problem.
abruptly
That's why
cuts
I
off
keep
the
stopping.
oxygen to your brain. So that's why it's
Damn it.
considered
Took up so much
epilepsy is considered not epilepsy. Status epilepticus is considered a medical emergency because you're having a seizure longer than 5 minutes or multiple seizures like in a row. They might have a seizure, have like a couple minute break, and then have another seizure. So they're continually having seizures. We had a couple patients recently in the hospital for this. So there's a number of gamuts that can cause a seizure. Allergies, tumors, anything that's going really on in the brain. Drug, alcohol, fever, head injury, hypertension, hypoxemia, metabolic causes. But there are triggering factors like increased physical activity, excessive stress, hyperventilation, fatigue, alcohol, caffeine, flashing lights. So all of these are triggering events. And there are new studies or studies with women where during menses can increase females from into having seizures. There are different types of seizures where they're generalized, partial, or unclassified. General seizures usually occur in usually the whole brain is affected, or the whole cerebral hemispheres, or both, I should say. Partial seizures, it's usually localized to one area. Unknown seizures, guess what? It's unknown. They don't know, or it's unclassified. There's incomplete data. Any kind of provoked, it could be structural changes or some infection like abscess or encephalopathy or something like that, or a stroke that can cause structural damage to the brain. They cause seizures. So you will need to know the types of seizure or the seizure actions. The first one is absent seizure. This is just a brief loss of consciousness. You might see blank staring, or eyes may flutter, or they might have these automatisms. These are involuntary behaviors. You might see them like clicking their fingers, maybe smacking their lips, but it's uncontrolled movements that they're doing. Those are called automatisms. Tonic-clonic is probably what most people are familiar with. It used to be grand mal seizures, where they occur 2 to 5 minutes. They might bite their tongue, they might be incontinent. Usually they're asleep. They have this post-ictal phase where they're asleep for a period of time after their seizure. Fatigue, they'll have some confusion. They'll be lethargic, maybe shallow breathing. But this type of seizure, it begins with the tonic phase, which is muscle stiffening, and then it continues to this rhythmic jerking. So when we're watching or we're assessing a patient having a seizure, we have to write down exactly, did the eyes roll back? Were they foaming at the mouth? Did they have this rhythmic jerking? Did they have that tonic phase? Because that will help the neurologist diagnose the type of seizure and treatment. So tonic seizure, so that's just like it says, like a part of the tonic-clonic, where it's just muscle stiffening for a few seconds to several minutes. They'll have loss of consciousness and some autonomic changes. Maybe they'll have apnea, vomiting, incontinence, or they might be drooling a lot. The other ones are clonic seizures. So this is the other half of the tonic-clonic seizure, where this is several minutes of brief jerking of extremities. So they just might have the brief jerking, and they might not have those that tonic phase. Myoclonic is the same thing as a tonic-clonic. I feel like I'm making a drink. A tonic-clonic, but just a few seconds. It's not the full up to 5 minutes. It's quicker, but they still have the tonic phase of muscle jerking and or muscle tightening and brief jerking of extremities. And then atonic is where they just have a loss of muscle tone. I don't know if those videos are on Blackboard, but this is a person that's kind of walking around and all of a sudden they just fall. They just totally lose muscle tone and they fall. And then they have like confusion following. But you will need to know the differences between the type or the seizure actions. Partial seizures, so this includes one half of the hemispheres or one side of the hemispheres. It doesn't include the whole brain, it's localized. So complex partial is the patient may want, or the person might wander around. They might seem conscious, but they behave inappropriately. They might have those automatisms, like they're picking at their clothes, they're chewing movements, they're doing something.
Is it always the same at the time or no?
Probably, yeah. They usually, if someone's having the same type of seizure all the time, they have the same activity. Simple partial is their awareness, memory stays intact, and they are still conscious. So the main difference between the partial and the general is that consciousness. So diagnosis is EEG, get those electrodes on the head. Let's look at that electrical activity. Usually, so you need to wash some nursing care that I don't even know if the book goes into it, but usually you have to wash their hair has to be clean, and then you put the electrodes on, and actually what they're doing during the EEG is trying to cause stress to the patient to see what their electrical activity is in the brain during that stressful environment. Are they going to go into the seizure? If they have a seizure, then it will show where that seizure it is. We're starting to do a couple of 24-hour EEGs or continuous EEGs at the hospital now. That's kind of new the last couple, like 6-7 months, I think. I have a question. So
Obviously, like, there's a difference. Like, the 24-hour EEG, like, I've been in the room, like, when they do the actual EEG, and they definitely are, like, stressing them out, like, flashing lights
Yeah.
and, like, saying stuff. But they don't do that with the 24 hours.
no, the newest one, they don't do it because to see what happens naturally.
So they're not trying to, like,
No,
make
because
the
their
thing that
technician's not even in the room during
Yeah,
that
no.
time. They just are like, here it is, you're on your way.
So
Yeah.
if they were to have a seizure during an EEG, would they, like, call people into the, because they usually keep the door closed while they're doing all that, would they just let
Yeah,
them go through it?
Well,
or do they call them out?
they're prepared to, if it gets into the status epilepticus where it's, lasting longer, then nursing care in the brain. Nursing care, what we're gonna do during the seizure is important to know. We wanna turn the patient on their side because because usually they're increased in drooling. So we wanna make sure they're not gonna aspirate anything. So we turn them on the side, protect them from injury. Because of that rhythmic jerking, we wanna protect their extremities. Do not force anything in the mouth. There used to be wives' tale about forcing a leather belt or a leather wallet in the mouth. This goes back a long time ago, but we don't force anything into the mouth. Loosen any restricted clothing that they have. Do not restrain the patient. You always wanna just guide their movements. You never wanna restrain. Ensure IV access is nearby, if not already in. Record the time the seizure began, their activity, and when it ended. You have to record everything. Have an airway. If they're not on a ventilator already, have an airway nearby because we gotta give them oxygen. So be ready to protect their airway if need be. If someone is on the floor, you're out in the community, someone's having a seizure, just put their head in your lap to protect their head from any kind of damage or anything, trauma. What to do after the seizure is we want to record, like I said, keep the patient on their side, do those neurological checks, vital signs, assess for any kind of injuries, allow the patient to rest. They might have that postictal phase. You need to make sure that they can rest, reorient them when they start coming to, determine if there was an aura, because sometimes people that have epilepsy would say, yeah, I felt it coming on. I could tell. My brother-in-law that fell out of the tree stand, he also had epilepsy. He's a great neuro patient. And that was one of the things after he fell out of the tree stand, I'm like, how do you know that because he kept on saying he fell asleep, then he fell out of the tree stand. And I'm like, how do you know you didn't have a seizure? And one of the things was he was up after. He didn't fall, and he was not sleeping. He goes, after I have a seizure, I'm like out cold for like an hour or two. And he was up after it, so he knew he fell asleep and just fell out of the tree stand. But, so allow him to rest, determine if there is an aura, and you can have him keep a journal of like, these are the triggers that I had before I had the seizure, to just try and record, and it's just more education for the patient for future. Record what activity happened first. Did they have rhythmic jerking? What were their activities? Like I said, eyes roll back? Were their extremities clenched? What happened? What bodies were involved? What were their arms, legs, whatever? Any automatisms? Did they do any kind of special movements? Incontinence, are they incontinence? Any weakness? Were they able to speak after the seizure? Did they sleep or were they confused? So all of these things we're writing down and charting for the physicians. Here's the auras, and it's like taste, sounds, any kind of dizziness. These were a lot of the questions that we ask before, like when the patient comes through. Do they feel anything like this, or have any of this before they have the seizure? So medications, you'll also need to know about is anti-epileptic medications, because they slow the rate of neural activity. It's not a cure, it's just slows the neural activity, hoping that a seizure doesn't occur. Doses are adjusted to achieve therapeutic blood levels. So someone that's having seizures, they're on medications, and say they have a seizure, but they're still compliant with their medication, they might be put on a different medication or increase their dose or something. So someone that's having seizures, their medications are monitored closely. And I think you won't be surprised at any of these medications. Some of you guys have probably given these in the hospital. Dilantin, Cerebrex, there's a lot of them. Depakote, this is another one that's, or Keppra. We gave that a lot. Gabapentin, you'll see that the rest of the afternoon. But we want to educate them, make sure they take that medication on time, take them as prescribed, don't ever double up on a dose, avoid oral contraceptives, Coumadin, because they decrease the effectiveness of the medication. I want to go back to take them on time. So if you have a patient that's NPO, you know that they take Keppra, they take an anti-seizure medication. You want to make sure that you let the doctor know, look, this patient's NPO for this surgery, this problem, but they take this one and this one at home. And sometimes it does take the nurse to bring that to the doctor's attention to say, hey, we need to get some IV Keppra, we need to get some IV anti-epileptic medications, because we don't want this patient to have a seizure. Sometimes build up to sensitivity to the drug, and that's why they might have what they call a breakthrough seizure, and that's when medications usually change. Oral care is really important with medications, because